Thank you for that introduction, and thank you everyone for joining us today. As mentioned, my name is Dr. Rose Nash, and I'm the Director of Research and Development at GT Molecular, where I've overseen the development of our COVID-19 wastewater testing service. I'm happy to take this opportunity to highlight the rapidly evolving technologies for quantifying COVID-19 in wastewater, and to share the lessons we've learned over the last several months as we help develop and implement our statewide surveillance program, and then went live in several communities around the country. COVID-19 has affected all of our lives. That said, the impact on our daily lives has largely been due to the policies and lockdowns that have protected us from the exponential spread of the disease. While effective, lockdowns are detrimental to the economy and our way of life as social creatures, and thus we're eager to get back to life as usual. However, returning to life as usual requires a comprehensive, data-driven approach and an early monitoring system for potential new or worsening outbreaks. It is likely at this point you've seen a news story or two about using wastewater as a means to monitor COVID infection levels or prevalence within a community. This became of high interest early this spring when early pioneers in the field started to report that they could detect COVID-19 in wastewater. And not only could they detect it, they could quantify it, and that the levels they measured often correlated with disease levels within a community. As the pandemic progressed, the field of wastewater-based epidemiology has evolved at a rapid pace. Now, not only can we estimate the level of disease within a community by testing at wastewater treatment plants, we can travel through the sewer, if you will, going upstream of the plant to collect infection level data at neighborhood and even at the building's level. I highlight here a news story that just came out of Colorado State University in the last few weeks, as well as a very similar story coming out of the University of Arizona. By monitoring Colorado State University's dorms, our protocol that we developed with CSU scientists was able to identify a campus outbreak and trace it to 2 dormitories. The dormitories were placed on quarantine to stop the spread. This inexpensive testing strategy, in which we are able to monitor an entire facility in just 1 sample, will likely save the university millions of dollars by allowing them to stay open, and could save lives next month as students make the decision whether or not to head home to see their elderly relatives over Thanksgiving. As we zoom out and think about applying this technology to the neighborhood or the community level, I like to discuss the use of this in providing more accurate disease estimates for economically disadvantaged neighborhoods. It has been clear since the beginning of the pandemic that this disease disproportionately affects the economically disadvantaged, and that most disease estimates are often incorrect due to the lack of access of quality care and thus testing of these individuals. By monitoring at the neighborhood level, we can get better insight into the true disease levels in these communities at no cost to the community members, and thus provide cities the much needed data required to make data-driven decisions around community interventions, policies, or testing strategies, while also providing cities and public health entities the ability to monitor the success or failure of these spread mitigation policies, such as safer at home policies or mandatory mask wearing policies at the neighborhood and community level. But I'd like to point out that probably the most powerful use of this technology is as an early warning system for new or worsening outbreaks. The use of this technology as an early warning system is made possible by the unique life cycle of COVID-19 and infected persons. SARS-CoV-2, the virus responsible for COVID-19, although a respiratory virus, is actually shed from the intestines a full week before symptom onset, and thus swab testing can be performed and reported. Because of this unique viral life cycle, and the fact that everyone within a community provides a sample in their restroom each day, wastewater testing can provide communities like yours and facilities within your community a quick readout on levels of infection. On the right, I'm showing data reported by the Centers for Disease Control for a community around Memorial Day weekend, where there was relaxed social distancing reported. The COVID-19 measurements in wastewater are shown as the pink line, identifying an increase a full week before these cases started showing up at the hospital. This early warning system was able to alert the hospitals about a possible increase in cases and provide the county public health organization with important feedback on their containment policies. So how is this type of analysis performed? How do we go from a wastewater treatment plant or a facility such as a dormitory to a readout on the level of disease in the area? The first step is collecting a representative sample for analysis. I'm now going to hand over the presentation to Senior Product Support Specialist at Teledyne ISCO, Stephen McManus, to discuss proper sampling and equipment used in this process.
Thank you, Dr. Nash. I too will welcome everybody who is attending today's webinar, and I hope you find this very educational and useful. If you have questions, please submit them via the Q&A function of Zoom. Teledyne ISCO as an organization and is an independent organization that was started in 1958. In 1971, Teledyne ISCO introduced the first automatic wastewater sampler to the market. Teledyne ISCO is now the world leader in samplers. For today's agenda, we'll be covering sampling methods for COVID-19. I will cover the types of samplers that can be utilized to perform that sample collection. And there will be recommendations based upon the location for COVID-19 studies. There is a link here in this slide that allows you to look up and determine various guidelines associated with sampling for COVID-19. There are a number of methodologies that can be utilized to collect a sample. The first one is a manual grab sampler. This can be performed manually by using a dipper, which is a cup or a container that is attached to a pole that is then lowered into the source to pull the sample out. The pros of such a methodology: it's a simple tool. There's not a great degree of complexity involved, and it's fairly simple to perform. The cons of using manual samples of this nature is, one, you are at a greater risk of becoming contacted by the sample itself as you are transferring the sample from the device used to collect the sample to the bottle that will be brought to the lab. Thus, it can be unhygienic. It is more time consuming because it involves personnel making trips to the field to the locations that the sample will be drawn from. There's a high degree of variation in the sample collection depending upon the personnel performing the sample collection. And that collected sample represents that singular moment in time of what was in the source rather than a conglomerate of samples collected over a period of time, so that one may be able to collect and identify sources in that sample throughout a longer period of time. The other methodology is using an automatic sampler. As there is no personnel becoming directly in contact with the act of collecting that sample, it is more hygienic. It is also quick and easy and less time consuming because once you've deployed the sampler, it does the job. The cons involved with this is elevated cost because equipment would need to be purchased. An automatic sampler consists of several components. You have your intake strainer and the suction line that will be used to draw the sample up to the pump. Typically, this will be a peristaltic pump that is controlled by a microprocessor-based unit and user-defined programming that indicates when that sample should be collected and at what volume and what bottle if you're using a multiple bottle sampler. The operation of that pump is initially a purge, which the pump will run in reverse to remove any residual liquid that has migrated up the line since the last sample collection. This ensures that any water drawn in is now representative of that moment in time from the source. The pump will then stop and change directions to pull the sample up, and typically a sampler will have a means of detecting liquid to highly control the accuracy of the volume delivered to the bottle. Once the sampler has detected the amount of sample that it should deliver to the bottle, again, it stops the pump and it will begin to run in reverse to purge the line of that liquid so that the line is cleared and there is no residual sample remaining in the line that will open the door for cross-contamination of samples. The COVID sampling method involving automatic sampling typically will involve a composite sampler, which utilizes a single bottle. A series of samples over a period of time, typically one day, will then be placed in that bottle, and the samples will be collected based upon user-defined intervals. At the end of the sampling routine, the sample in that bottle represents a composite of all the samples collected throughout that sampling period. Today, this is the most common method utilized for COVID sampling. However, there is an alternative method that is also beginning to have a footprint in the sampling, as it provides a little more detail. This would be the sequential sampler option. A sequential sampler involves multiple bottles where a single sample or multiple samples are placed into that bottle, and then those samples are collected at a user-defined interval. That could be time or flow, which I will cover in greater detail in a moment. Then the bottles are switched based upon user-defined time intervals. A 24-bottle sampler will often have its bottle switched every hour, so that at the end of the sampling routine, each bottle represents the state of the source that sample was collected from for that given hour. And then the next bottle represents the following hour, and on down the line. This allows you to track the trends throughout the day within that sample source. The programming options that are utilized can vary. The most common method right now that would be utilized would be to take time-paced samples of fixed volume at regular intervals. That can be a sample collected every 15 minutes. That could be a sample collected once an hour. Another method involves flow pacing. To flow pace a sampler, obviously there is a need for a flow meter that will provide volume-based information for that sampler so that it may determine when to collect a sample. The graph you see there on the right, you can see that the sample intensities are greater when the flow rate is higher and lower when there is less flow in the channel being monitored. Another method is to take time-based samples, but adjust the volume that is delivered to that bottle based upon flow information that has been monitored and collected over that time interval when that sample is being collected, or at the moment in time when the sample is being collected. This would be time-paced, volume-dependent flow sampling. Determine locations and methodologies for those various locations. The first location we're going to talk about is at the building level. This could be dorms, hospitals, nursing homes, or specific industrial facilities. The purpose for monitoring at these locations would be to determine viral concentrations and infection prevalence. Grab sampling with an automatic sampler is the methodology that would be utilized at these locations. The type of sampler that would be utilized in this location would be a portable sampler with ice or gel packs to chill the sample. If one is going to multiple locations, a portable refrigerated sampler is another option to consider. And also sequential sampling will help effectively manage those multiple locations for those short periods of time, where each bottle, as one is moving from site to site, would represent that location. Typically, the frequency of monitoring would be twice a week per location for viral concentration. One could include multiple grab samples over a period of time to determine infection prevalence. The next sampling location would be within the wastewater sewer network. And the purpose of this would be to determine local area community spread within specific neighborhoods. The composite sampler with an automatic sampler method would be used in these locations. And the programming would typically involve time-paced samples with volume-dependent sample delivery. This would be a portable sample with ice or gel packs utilized to chill the sample. The frequency of sample collection would be at minimum once per hour over a 24-hour period. One could certainly have more frequent samples, such as once every 15 minutes, to get greater granularity. If one is taking flow-based samples, the volume interval would be site-dependent. One must know what the typical volumes are day in and day out at that location to determine what the volume intervals between samples should be. The third location for sample collection would be at the treatment plant influent or a catchment basin area. The purpose of this sampling methodology would be to determine a catchment-wide or a city-wide community spread prevalence. Sampling will be performed by a composite or a sequential automatic sampler, and that can be either time or flow-paced sample intervals. Being a permanent location, the sampler of choice would be a permanent refrigerated sampler. The frequency of sample collections would be typically once every 15 minutes over a 24-hour period of time. If one is performing flow-based sampling, again, one must know what the typical volumes are at that location day in and day out to be able to determine what the volume interval between sample events would be. As with any sampling purpose, there are certain safety guidelines that should always be followed. Normal practices would be including the wearing of gloves, masks, or boots to avoid contact with sample. And if one is entering a manhole, use of a ventilator, an air quality monitor, a winch to raise and lower personnel in and out of the manhole with a harness, as well as other appropriate PPE equipment. And with that, I will turn the presentation back over to Dr. Nash.
And now I'm going to fill in this roadmap or workflow to explain how we go from the sample collected via the methods discussed by Stephen to viral concentrations and ultimately to estimates of the level of disease within an area. Before we dive into the nitty-gritty of sample analysis, I would like to take a moment and quickly introduce GT Molecular. We are a team of professional diagnostic developers and molecular biologists who develop ultra-sensitive molecular tools for use in monitoring cancer in patients undergoing treatment, as well as many other applications, including pathogen detection and quantification. We were in a unique position to contribute to wastewater testing due to our ultra-sensitive technology for viral quantification. As the first stories came out on the potential benefits of wastewater monitoring of COVID levels, we had already developed a COVID-19 diagnostic for clinical use with nasal and oral swabs. We quickly repurposed our diagnostic test for use with wastewater samples when the state of Colorado reached out to us to participate in developing their statewide program. I'd like to use this collaboration with the state of Colorado to explain the molecular workflow that we developed for them and the lessons we learned along the way. Colorado's wastewater testing efforts started in early spring when a group of 15 wastewater treatment plants started participating in a nationwide wastewater surveillance pilot program. They joined a collaborative and included the Colorado Department of Public Health and Environment on their weekly discussions. Some additional wastewater treatment plants attempted to send samples, but the pilot program was at capacity. Later in the spring, this pilot program transitioned to a fee-for-service program. With the desire to develop a homegrown testing method, the original Colorado Collaborative and the wastewater treatment plants not included in the pilot study formed a consortium, including the Colorado Department of Public Health, Colorado State University, and GT Molecular. Between May and June, GT Molecular and Colorado State developed the molecular workflow for viral concentration determination. CSU and the Department of Public Health developed a dashboard where the statewide data would be centralized, and the participating wastewater treatment plants provided samples for protocol development. In this time, the group also developed and submitted a proposal for funding, and the governor's office ultimately provided over $500,000 to fund the testing initiative. In July, the surveillance program went live, with GT Molecular and Colorado State providing their developed workflow and testing protocol to the 20 wastewater treatment plants twice a week. Around the same time as going live for the state, GT Molecular started marketing this service to wastewater treatment plants and municipalities outside of the collaborative and has expanded this testing service to customers around the country. As we were developing our own procedure for use in Colorado, we had a couple requirements to ensure that we were producing data for action. First, the procedure needed to be high throughput. In other words, we needed to be able to process a lot of samples every day. Secondly, the procedure must be rapid, such that we can turn around this data to the state within 24 hours. This was absolutely critical. The virus responsible for COVID-19 is tricky. It's highly infectious and deadly, but it has an Achilles heel in that it is excreted in waste and thus throws up a red flag for us to see if we are looking, several days before symptom onset and outbreak spread. To truly harness the power of wastewater monitoring, as to exploit this Achilles heel and prepare for outbreaks, data must be turned around in near real time, as to ensure that we are in that actionable window and provide the most impactful data possible. Additionally, the procedure must be highly reliable, such that the data that we do turn around rapidly can be used to support community leaders in decision-making around policies that protect us from the exponential spread of the disease. And lastly, the procedure needed to be ultra-sensitive, capable of measuring very low levels of SARS-CoV-2 in wastewater, such that we can establish a baseline and detect increases in signal as early as possible. Across all the methods reported to date, there are general themes in how testing is performed. Often the first step, once a sample arrives at an analysis lab, is to remove solids through filtration or centrifugation. Next, the virus is concentrated. This is because the virus is present in wastewater at such low concentrations that even the most state-of-the-art technologies often reserved for human or cancer research and forensic labs often cannot detect the virus at these concentrations, and thus requires being concentrated. As we will discuss later, this is one of the most labor-intensive steps in the process that often produces bottlenecks in testing and can result in long sample backlogs. Once the virus is concentrated, the viral RNA is extracted. This is required because the molecule that we detect and quantify is RNA in the case of COVID-19, and RNA is found on the inside of the viral particles. Therefore, in this step, the viruses are lysed open to release their nucleic acids. The nucleic acids are isolated and then concentrated for quantification. Next, viral RNA is quantified via PCR technologies, which consists of modern molecular techniques for amplifying and quantifying nucleic acids. And finally, the results from this viral quantification procedure are analyzed and converted to SARS-CoV-2 copies per liter. Some groups use different normalization factors in this process, and others then take the normalized data to calculate the reported estimated number of cases within an area. As we were getting started, we looked at the common workflows used for this type of analysis through the lens of how to meet the state of Colorado's needs. In doing so, we identified 2 steps in this process that could be optimized for throughput and sensitivity. The first step, right for optimization, was the viral concentration step. A polyethylene glycol viral concentration step is common practice in many commercial and academic laboratories. This procedure requires a 2-hour centrifugation step, and due to limited spacing in the centrifuge, a single operator can only process a handful of samples in a full workday. And often labs don't have several of these large centrifuges around for multiple operators to use. So this step really represents a bottleneck in testing that often results in the missing of that critical window for actionable data. In working with the state of Colorado, we needed to be able to test a lot of samples on a regular basis. And it was important to us that the data would be turned around within 24 hours. So our first mission was to find alternatives to this step with similar or improved performance so we could eliminate this source of bottlenecking. In doing so, we developed a method in which one operator can concentrate 1 sample every 3 minutes, allowing for us to build a capacity of several hundreds of samples per day. The next step we identified that we could optimize for the state's needs was the viral quantification method. As experts in droplet digital PCR, we developed our method using this technology for ultrasensitive RNA quantification. Droplet digital PCR is the most advanced technology available for quantifying nucleic acids and provides several benefits over the classic quantitative RT-PCR approach. The first step in performing droplet digital PCR is to partition the reaction into 20,000 microscopic droplets. These droplets are then allowed to cycle for amplification and are read individually by a microfluidic empowered imaging system. The important takeaway from this discussion is that running a single sample in droplet digital PCR is like running the sample in 20,000 replicates, and thus provides unparalleled reproducibility and statistical power. Additionally, this technique provides an absolute measurement, not relying on a standard curve of reference material for determining concentration, freeing up more wells for sample processing and eliminating any errors that reference materials can introduce to quantification. But most importantly, the digital PCR technology is significantly more sensitive, with limits of detection of just a few molecules per reaction, compared to RT-PCR, which requires upwards of 1,000 molecules per reaction for detection. This attribute alone allows digital PCR to detect COVID at lower levels than standard techniques. To demonstrate this level of sensitivity, I'm showing data from our analytical validation study that we performed before initiating customer testing. What we did in this study was demonstrate the workflow we had developed was capable of accurately measuring the virus across a broad range of relevant viral concentrations in wastewater. You can see by the chart on the left in which we are plotting the concentration that we measured for each sample against the expected concentration for each sample based on dilution, that we have a nice broad linear dynamic range with minimal variability. By focusing on the lowest concentrations tested in this experiment, we moved to the chart on the right, in which we tested 20 replicates at the lowest bounds of the technology sensitivity. In doing this experiment, we defined our limit of detection as 5 molecules per droplet digital PCR reaction, which back calculates to approximately 600 copies per liter of wastewater, which is represented by the concentration in gray, which resulted in the detection of the virus 19 of the 20 times, or 95% of the time. Our limit of quantification was defined as 2,000 copies per liter. This is the concentration in blue, in which we observed less than 20% variability. Notice the smaller error bars for this concentration. This is the concentration in which we are confident reporting concentrations. While sensitivity is important, it is also critical that we have a high level of precision in our measurements and thus increased confidence in the reliability of our measurements. As we started developing our protocol for the state, we read several reports from other groups stating that viral recoveries, or the amount of virus that actually makes it through the process and is quantified at the end, ranged from 2 to 14%. Low viral recoveries, such as 2 to 6%, significantly hinder the sensitivity of this kind of approach. Additionally, the variability from 2 to 14% is huge. To put this into context, if a sample varied from 2 to 14% from day to day, you could have as much of a 7-fold change in signal just because of the method alone. Going from detecting 100,000 viral copies per liter of wastewater to 700,000 copies per liter overnight would be enough to raise some big red flags for a potential outbreak. So this source of variability must be controlled. We overcame this potential source of variability by including an internal process control, or what some may call a spike control, in every sample that we process. In this process, we add a known concentration of a bovine coronavirus to every sample. The bovine coronavirus is highly similar to SARS-CoV-2, but its sequence differs enough that our quantification method can differentiate the two species. We then process the sample as usual, and in step 6, when we quantify the virus, we also quantify the bovine virus that we spiked in. Because we know how much we added originally, we can determine the amount of the virus that was lost throughout the processing steps and normalize the sample for viral recovery. Here I am showing data from our analytical validation testing, in which we tested 200 different samples from 50 different locations to assess the variability of that bovine coronavirus viral recovery from day to day and from sample to sample. These locations included primary influent into several different wastewater treatment plants, academic facilities and dormitories, and neighborhood monitoring. The sample types included flow-adjusted and time-adjusted composite samples collected using autosamplers, as well as grab samples. This data shown here, in which every data point, in which each data point represents an individual sample, was collected on multiple days by 3 different operators. Our procedure's average recovery is 20%. And the range we observed from sample to sample was 5 to 45%. This range represents a 9-fold difference from the maximum recovery to the minimum recovery, and demonstrates the power of normalizing out this type of variability when you're looking for true trends in this type of data. Using this data to identify sources of variation, we found the largest amount of variation to be from day to day, with much less variability introduced by sample location and operator. Again, this variability is identified and accounted for in each sample through use of that coronavirus internal control that normalizes our measurements. From our analytical validation studies, we implemented a series of quality control metrics that we provide data for with each sample we process, as shown in the example report here. This report also serves as a nice transition into the next thing I'd like to discuss, which is using this data to estimate the number of COVID-19 cases within a catchment. Viral concentrations measured using these types of approaches can be used to estimate the number of COVID-19 cases within a catchment. This is done by dividing the viral load of a given wastewater treatment plant by the viral concentration of an infected individual on a given day. The daily viral load of the wastewater treatment plant is calculated by multiplying the viral concentration measured by the types of techniques we're discussing today by the facility's flow in liters per day. The viral load of an infected person is calculated by multiplying the viral concentration in feces, which is reported in viral copies per gram of stool, by the average mass of a stool in grams. For the model published by Curtis et al. Of Hampton Roads, the 90th percentile concentration of virus in stool comes from a published study by Wuffel et al. In this study, 9 patients were monitored over 22 days. and a triangular distribution was fit to the data from a study by Rose et al. For the average stool mass before a Monte Carlo simulation was run. While this method provides a way to translate viral copies per liter, a somewhat abstract measurement, into a tangible piece of data that's easier to conceptualize, such as cases within a town, this model and all models currently at use for this purpose rely on several key assumptions. First, these models assume that each infected person provides one average size stool to the wastewater treatment plant each day. Next, these models assume that no virus is lost as it travels through the sewer and to the wastewater treatment plant. But most importantly, these models assume that we have an accurate understanding of how much virus is actually shed in feces. It's important to note that the model discussed is based on the most thorough study published to date on fecal shedding rates, and it only included 9 patients, which is not enough patients to feel confident that the results are representative of the greater population. And lastly, these models assume that infected individuals shed similar levels of virus despite their stage of infection, which we know to be false, their age, whether they're symptomatic or asymptomatic, and whether they have coexisting morbidities. What I've learned and hope to have passed along in explaining this process is that disease estimation can provide an estimate to the level of cases in a catchment, with an emphasis on the word estimate. I found in talking with several wastewater treatment directors and clients that the copies per liter measurement is sometimes abstract and hard to relate to. Disease estimates put this data into context for people, which I think is important. However, there are several drawbacks to using these models due to the assumptions that must be made for their use, and they should not be relied on too heavily. Models are still being refined, however, and the Center for Disease Control is expected to release a model to address some of these assumptions and to provide harmonization across different methods and testing labs in the near future. Forward thinkers like the state of Colorado, Hampton Roads, cities in Utah, and all of the communities who initiated this testing early have paved the road for this sort of monitoring to stop the next pandemic in its tracks before it can cause the type of harm and exponential spread that COVID-19 has. For these techniques to make the most impact, however, they must be rapid, providing results in near real time. They must be ultra sensitive to establish accurate baseline measurements. They must be cost effective such that all communities can participate in these types of programs, and they must be adaptable to viral evolution. The truth is that viruses evolve, they change, they constantly adapt, but so can this type of technology. What the wastewater-based epidemiology field has learned over the last 6 months will forever shape how we monitor for new outbreaks and how we monitor the effects of different policies like mask wearing and social distancing on viral spread. When the next outbreak happens, we'll already know how to design the best sampling plans for representative data collection, how to concentrate virus for quantification, the best methods to ensure reliability, and we'll be able to monitor communities before FDA-approved diagnostics are even available. In conclusion, while the COVID-19 pandemic will someday end, and not all too soon, these testing methods that came out of this pandemic will continue to help mankind stay ahead of our next viral threat. And in this future, our wastewater operators and facilities will represent the country's first line of defense in harnessing this information and stopping future outbreaks through outbreak analytics. And with that, I'm happy to hand over the presentation and answer any questions you might have. Thank you.
Thank you, Dr. Nash and Steve, for providing this presentation. Today, we're also being joined by Cashel Taverdi to also help answer some of your questions. With that, I will turn it over to Steve, and he will share the questions that we have been receiving.
Thank you, Sharon. We do have a number of questions here. We will try to get through as many of most of these as best as possible. One of the reasons why we've requested that questions be submitted to the Q&A is because they are logged and recorded, and therefore we are able to call them up and answer any questions that we're unable due to time constraints to answer today. We will provide answers to the submitter of the question via email. The first question that is in the list here relates to what are the advantages of time versus flow-paced sampling. One of the application conditions that one could be faced with was a high variability in the amount of flow that can occur from time to time. So if one is simply taking time-paced samples and we're at a very minimum amount of flow, and the sampler attempts to collect the sample, it may not be able to, because there may not be sufficient amount of flow in the source to draw the sample in. The advantage with the flow-paced sampling approach is that as flow elevates and increases, the frequency of sample collection increases along with that increase of flow, and likewise as flow decreases, the intensity of sample collection decreases along with that proportionally. And if we find ourselves in a condition of no flow, what will happen is that no samples will be collected because there's no flow information to trigger that sampler into collecting a sample. The requirements that are a necessity for a flow-paced application is that there be a measure of consistency, day in and day out with the flow at that, so that one can devise a flow-paced sampling interval to guarantee that we're able to collect samples throughout that day that are representative and proportional to the flow over that day. However, if we have an application that has a high degree of variation in the amount of flow that can occur, for example, if we have one day that we may have 10,000 gallons of flow at a given location, and then the next day we have 1,000,000 gallons of flow, it would be impossible to devise a flow-paced program that would allow one to be able to collect samples throughout that day. Either you're going to have very little sample because we didn't have a lot of flow, or we're going to have too much sample and the sampler will be, bottle will be full well before the end of the 24-hour period of time. That is where time-paced programming becomes a little more advantage, because it guarantees that we're going to be able to collect sample from that location over that full 24 hours. The next question we have here, it looks like it is going to be a kind of a two-part answer where both Dr. Nash and I can provide the answer. The question is, what biological hazards should be considered when handling a sampler by humans in the COVID-19 pandemic? What protection is needed? The answer to that question is actually a little larger than just due to COVID, because there are other things in sample that should, one should be very cautious about. It need not be COVID and COVID alone. So for sampling in general, it is recommended to have the appropriate protection, gloves, PPE. You want to maybe have a mask if you're potentially going to be exposed to splashing or aerosolized sample, and protect oneself for a variety of things above and beyond COVID. I will also ask Dr. Nash to focus in and provide answers on COVID, as well as any other peripheral information she may have to provide on this question.
Thank you, Steve. This is a common question that we receive from anyone getting started with the testing program, because we all want to take care of the people who we work with. But right now, the general consensus in the scientific field is that it's very likely the virus excreted in waste is non-infectious. So there have been a couple large studies published in both Science and Nature that have shown that while scientists have been able to culture virus from nasopharyngeal swabs and saliva, that they're not able to culture the virus from waste, even though the RNA from the virus is present in very high levels. So to actually be able to culture a virus, it has to be infectious. So right now, the theory in the field, and of course everything with COVID-19 is always changing, is that the virus is not actually infectious. However, myself and my team, when we're processing these samples, we of course process them as biosafety level 2 samples, wearing all the appropriate PPE to keep ourselves safe. But we're mostly more concerned about the other things that can be found in waste, like hepatitis and norovirus and other human pathogens that can be present.
Thank you, Dr. Nash. The second question here is somewhat related. The question is, what is your assessment of potential COVID-19 infection while operating the sampler? Is there a difference between inhalation of aerosolized emissions from wastewater and wastewater itself as a potential path to get the infection with the virus? I think the answer that was just given on the previous question kind of covers that, in that the COVID-19 residual that is in wastewater is effectively dormant and no longer active. So therefore the risk of, becoming infected with COVID when working with wastewater is at this point in time believed to be non-existent. However, as Dr. Nash indicated, there is a variety of other constituents in that sample, that wastewater, that should remain to be of concern and would bear out the continued need to be very cautious in the approach so that one is able to, prevent any direct contact with those samples being collected.
Yeah, and Steve, the only thing I like to add to that when discussing this topic is that, the Centers for Disease Control have reviewed this data, and at this time, they're not recommending any additional protections for people who work in wastewater treatment facilities or have close contact with wastewater. As much as, it's scary that COVID is present, that kind of supports this idea that it's likely, non-infectious.
Thank you, Dr. Nash. There's another question here that relates to samples collected using the manual grab approach that are getting rejected by the lab due to high solid content. How can autosamplers help in this area? Well, from a practical standpoint of the sample collection, as I indicated in the body of the presentation, there can be a wide degree of variability in the quality of the sample when you're taking a manual grab approach, because depending upon the individual, there may be variations in how far down into the source they lower their collection bottle. They may be getting close enough down to the bottom where there's been sedimentation and solids have collected, so they may be getting a higher degree of solids that are disproportionate to the actual amount of solids that are in the sample, and that can certainly impact the quality of the sample being collected. I would also like to ask Kaushal Trivedi to comment on that particular situation as well.
Steve, you are absolutely correct that, basically in a manual grab process, the canister or cup, it picks up whatever present at that location. And the coronavirus has more affinity towards solid. That is what the research says. So Dr. Nash can comment on that, but that is what so far the research says, that it has a more affinity. So your representation can be misleading. Now, in case of autosampler, what happened that we use a strainer in front of the suction line. So it filters basically the large particles. So you don't get those kind of things in your sample. That's why the automatic sampler helps in this kind of study a much better way. But I can request Dr. Nash to comment that what is that virus affinity with the solid particle.
Sure. So it has been shown by a couple of groups that coronaviruses do tend to associate with solid material. So sure, it could misrepresent your sample. Additionally, when you have all of that additional solid material going into PCR for analysis, there's several inhibitors of PCR that are present in human waste. We alleviate this issue quite a bit by using droplet digital PCR over quantitative real-time PCR, and that it's more robust to these inhibitors. But when you do bring in a lot of waste from a grab sample, getting into that sediment, it does make the quantification a bit more tricky. In general, when we're bringing on new customers and getting them up and testing, we always recommend using an auto sampler because the data is in general just so much more robust and the samples are just easier to work with. However, we do like to keep grab sampling as an option for some of our customers coming online that might not have access to a sampler.
Thank you, Dr. Nash. I would also add that one of the things the automated samplers will perform, as indicated in the body of the presentation, is before it actually draws the sample in, it does a purge. And so that force of any fluid that's migrated up the line, as well as the air that is being moved down that line, will have a tendency to remove any solids that have settled in around the intake strainer and allow the flow to carry them on down past the strainer, so that when it transitions into that activity of actually pulling the sample in, it is pulling fresh sample as opposed to drawing in any sedimentation that is built up around the intake strainer. The next question in the list here indicates permanent composite auto samplers, time-based, refrigerated every 15 minutes, tracking the effluent flow of a targeted building are a good choice for considering based upon today's webinar. How does GT Molecular, ISCO, connect with those who want these services? For example, a university wants to buy samplers from ISCO. Does GT Molecular have a standard offering for the lab work and data assessment across the USA? Or, and Dr. Nash, I will turn this question over to you.
Sure, thank you. That's a great question. We have a lot of people who come to us, oftentimes universities, that are very interested in getting started with this type of testing. We always recommend using an auto sampler, just again, because of the quality of the data, as we just discussed. So at this point, when someone first comes to us, we usually connect them with our friends here at ISCO or other groups that rent ISCO samplers. And then all of our offerings are, as you mentioned, standardized. So we sell our kits online. Each analysis is $295. What that includes is, you place the order, we ship you testing kits. Each testing kit has all of the bottles required, to fill up and send back to us, as well as ice packs to keep the sample cold and a return shipping label. We receive that within 24 hours. Again, that's an overnight shipping label from anywhere in the United States, and then provide the data in 24 to 48 hours upon receipt of that sample. So, we work closely with ISCO and definitely recommend their samplers. But generally, when people come and reach out to us, our first point is to kind of help them think about how to set up a sampling plan, put them in touch with ISCO, and then once they have that up and running, they just, we ship you kits and you ship them back to us, and then we provide you data.
Thank you, Dr. Nash. The next question is, what is the maximum holding time of the samplers from the field to the lab? And can you accept samples from international locations? Dr. Nash, this is in your bailiwick.
Yes, absolutely. So the field has been coming around, doing a lot of experiments, we have as well, to try to understand, how stable is this RNA signal in wastewater. The number one recommendation that's come out of this kind of work is to avoid freeze thawing. So a lot of people think, if I want to keep this for a while, I should put it in the freezer. However, the actual process of freezing the sample and then thawing it for analysis is highly detrimental to the RNA signal. There have been studies, and we've shown in our lab, that the RNA signal at 4 degrees, so in standard refrigeration, is stable for at least 2 weeks. Some people have shown data up to 4 weeks. Our experiment hasn't gone that long yet, so I can't speak to that. But at this time, I would recommend, not holding your samples for more than 2 weeks at 4 degrees. A lot of our customers actually collect the sample and that day just transfer it to our bottles and ship it to us for analysis. And then it's really been stored at 4 degrees for only a couple of days. So you're definitely within that 2-week window that I recommend. But I do want to bring back to, one of the slides that Steve had in his presentation today, which was that Water Research Foundation guidance on sampling. This was a document that came out of a large group of experts in the field of wastewater and wastewater-based epidemiology. And they came together a couple months ago and made their expert recommendations on, setting up a sampling plan and how to store samples. And their recommendation right now as well is to avoid freeze thaws and to store the sample at 4 degrees for less than 2 weeks. So that's a really nice resource that I recommend everyone takes a look at if they're considering bringing on a sampling plan.
Thank you, Dr. Nash. The next question here, what is the maximum time allowed from collecting the samples to when it reaches the lab for analysis? Does it require ice packs or refrigeration when shipping? And Dr. Nash, I'll turn that one back over to you.
Sure. So great follow-up, because this is a very similar question to the last. So it does require shipping on ice packs. We like the samples to stay, close to 4 degrees always. It doesn't require refrigeration, but we ship the kits. They have an ice pack in them. Upon receiving the kit, the ice pack's stored in the freezer for 1 hour, and then it's going to be at 4 degrees. And that shipping arrangement that we've put together is validated to keep the sample at 4 degrees for 48 hours. So even though it takes 24 hours, there's that extra day of buffer just to be careful. And the maximum time allowed, would just be to, ship it to us as soon as possible. We try to not let the samples come up to room temperature just to stabilize that signal, and to ship it to us probably within a few days of collecting. But again, it's just important that we analyze within about 2 weeks of sample collection.
Thank you once again. The next question, does infiltration if clean groundwater affect the testing results, or do you compare virus numbers to concentrations such as suspended solids or a BOD rather than volume? And the simple answer that I would think on that would be there would be a huge factor depending upon the degree of infiltration that is taking place, because obviously there will be a measure of dilution taking place. However, I'm going to turn this over to the real expert on that, Dr. Nash, and allow her to put her 2 cents in it.
Yeah, so absolutely infiltration could definitely, change the results based on diluting the sample. We did take this into account when we developed our molecular workflow. So after we process the samples, we've concentrated them, they're going into our droplet digital PCR. We quantify in that step SARS-CoV-2, of course, that bovine coronavirus control for recovery, but then we also quantify an F-specific bacteriophage. So this is a little RNA virus that infects E. coli, of which we all have a lot of E. coli in our intestines. So this gives us a readout on the actual amount of fecal material present in the sample. And if there was, infiltration of clean groundwater or flooding or that sort of thing that would dilute the sample, we would actually get that in that readout. So what we do at GT Molecular is we test every sample for this F-specific prophage, again, as a fecal matter indicator. And we, after we've tested 10 samples, we establish a mean or an average for that reading, because we found that there's kind of a signature for the level of F-specific prophage for a given facility or a given building. So then we monitor that, and whenever we have a large decrease or a large increase, more than 2 standard deviations, it triggers a review of the data. So at this time, we're not normalizing to the amount of fecal material, although we are building a model to be able to do that. But we are looking for any major dilution. Haven't really seen that across the board for our customers. You know, a lot of our customers are in the state of Colorado, and of course it hasn't rained here in a very long time, so that might have something to do with it. But in general, we haven't seen much of a deviation in the F-specific prophage from sample to sample.
Thank you, Dr. Nash. The next question relates to what additional hardware do I require to flow paste the samplers? Well, the obvious answer for that begins with you need some device that is able to measure the flow and provide flow-based and specifically volume-based detail to the sampler. Teledyne ISCO does have a variety of flow monitoring equipment that would again depend upon the application conditions that we intend on monitoring in. That will help determine what is the most suitable option to select. And then there is also, beyond the hardware, there is a requirement to have some understanding of what the volumes, typical volumes, would be in that application to be able to devise a pacing routine around that given volume. If one is unable to, know what the flow is, it would be very difficult to be able to devise a flow paste routine, because you don't know, do I pace it every 100 gallons? Do I pace it every 1,000 gallons? If you do not have an understanding of what the typical flows are in that particular application. As indicated, ISCO does have a variety of different technologies to measure flow. They would range from devices that would be capable of measuring flow when there is a primary device, a flume or a weir that would be present at that location, to a variety of area velocity measurement devices that could be used in an application where no such primary device is present. One could also use some of the other methodologies for flow measurements, such as the Manning or data point, if one has done a hydrology study at the location that establishes a level to flow relationship. Kaushal, do you have anything that you would like to add to that question?
Sure. So if I have to answer this question based on type of locations you have, then, basically if you have a permanent location such as a treatment plant in Fluent, then you might have existing flow meter, and ISCO sampler has a flow meter port. So you can connect those flow meter with an ISCO sampler and you can take the flow paste sampling. And if it is a portable locations or applications, then our models such as 6712 and Avalanche sampler has a flow module which is integrated in this in the sampler. It's a very nice compact flow module that can easily slide in a slot provided in a sampler controller. And as Steve mentioned, these flow modules are also available in different measurement technologies depending on application. And even in the permanent flow meters, if you need any permanent flow meter, ISCO also offers open channel flow meters. We had not discussed here because this is a sampler webinar, but we also have open channel flow meter.
Thank you, Kaushal. The next question here: what tools are being used to analyze the data? I'm assuming this is referring to once the sample has been delivered to the lab, what is the methodology and the equipment utilized to monitor and evaluate the sample? And so therefore, I am going to turn this over to Dr. Nash.
Sure, thank you for that question. As mentioned in the webinar, we use droplet digital PCR to quantify the amount of SARS-CoV-2 RNA in the sample. This is a technology that provides us an absolute measurement. What this means is that it doesn't require on us running a standard curve of reference material. Each well within this analysis provides an absolute number of how many molecules were present in that reaction. We can then back calculate to the amount of copies per liter of wastewater by using all the appropriate concentration factors and dilution factors from the analysis. And then we feed that information into a mathematical model that was previously published by Curtis et al. To come up with estimates for the level of disease prevalence in the area. And this relies on more than just the information that we generate from the sample. It also requires that we know the average flow of which the time that the sample was processed, such that we can extrapolate this result to the entire day of which the sample was being collected. There's all kinds of great tools coming out and mathematical models that I think will be published in the near future. The Centers for Disease Control is working on this harmonized model that I think a lot of us will start using, that takes into account a lot of those assumptions that I discussed in the webinar around the loss of signal as it travels through the sewer, and the differentiation from day to day of how much virus is actually shed in waste. So there's a lot of new analytical tools that will be coming online, I think, soon. But right now, we're relying on that published method from Curtis et al. and recommending to our customers to use this data to monitor trends over time. We find that the signal comes up often 7 to 10 days before the positive results start showing up at the hospital or in the testing lab. So being able to monitor this over time is really the best way to analyze this data, which is why we provide our results in two ways to our customers. One in the report that I showed in the presentation that showed the quality control metrics, as well as the results. And then also on HydroView, which is our data tracking and sharing secure site that allows our customers to track their samples by location over time to look for these trends.
Thank you, Dr. Nash. The next question we have here is: sampling volume proportional to flow rate essential to calculate the number of infected people in the lab? That's a question that I will direct towards Dr. Nash.
Sure. So, we're able to give a pretty good readout using time proportional sampling. However, when we get into, really trying to nail down the prevalence within a community, it's nice to have that flow adjusted composite sample because we know it's a representative sample of that flow over the day. And the first thing that we do when trying to calculate prevalence is we take the concentration that we've determined in the lab and we multiply it by the flow for the day for that given facility. So by having that flow proportional data, it's just a more representative sample of that flow. That said, doing time proportional sampling is common, and I think we can still give, some pretty good estimates of disease prevalence. Again, as I said in the webinar, with always a strong emphasis on the word estimate when using those models.
Thank you, Dr. Nash. Next question is: how does soap or other pollutants/constituents influence the detectability of virus in wastewater?
Great question. I always like to bring up in webinars that we are really riding the front end of this thing. This is a new technology that we are, learning more about every single day. At this time, I haven't read anything about the effects of soap. However, I do know that the Water Research Foundation has recently funded 2 projects to really understand and better understand the different, constituents and properties that might be present. But I think that's a great question and something I hope that the field will get at in the near future.
Thank you, Dr. Nash. We have 3 more questions here. The first one is: how does this type of testing utilized at the university dorm locations operate?
Yeah, great question. So what we have found, we're working with several universities right now, and what we have found is they'll install a sampler at all of their different dorm settings. They usually have one dorm that they set aside as their quarantine dorm. It's always very interesting to bring on a new university with this type of testing, because we can always very quickly point out which dorm they're quarantining their students in, because they always have a really high signal. And then it becomes a game of whack-a-mole, really, where that quarantine dorm signal stays high, and then as there are small outbreaks within the other dorms, that triggers for university staff to go in and do testing to find the infected individuals and then to move them into the quarantine dorm. So you see the signals come up, and then the next week they've done their testing and moved, and it comes back down, and the quarantine dorm goes up. So I think a lot of universities are figuring out how to use this testing. If there's anyone on the call that is a university that's interested in this, I urge you to reach out to me, and I'd be happy to put you in touch with some of our university partners that are doing this. I have heard from our university partners that they're really happy with the extra level of data that this provides, and also the ability to reduce how much they have to swab their students. Because if a dorm stays consistently low, they don't have to go in there several times a week and do that painful swabbing process. Rather, they wait until the levels come up and they go in and identify the infected individuals. But we've really seen an uptick in our customers that are universities doing this type of testing, and it really speaks to how impactful it's been for them to find outbreaks quickly and to move infected individuals into a quarantine setting.
Thank you, Dr. Nash. This next question is also geared towards yourself. Is it possible to compare the results from different labs using the different methods available?
No. So we actually really urge people not to compare from lab to lab at this time. As I showed in the presentation, that there can be huge variations in viral recovery from sample to sample within a given day. And there is also huge variations in how much virus makes it through the analysis from different protocols to different protocols. So what we're urging the field to do right now is to consider adopting some harmonization controls, things like this bovine coronavirus that we use. If that was implemented into other workflows, like that polyethylene glycol concentration step I mentioned, it would really make it easier to compare from lab to lab and give us a more harmonized data set for the country. Because everyone's working with different labs at this point. But your answer to your question right now is we highly discourage comparing from one testing lab to another, just due to the inherent variability in the concentration step and the recovery from protocol to protocol.
Thank you, Dr. Nash. And the final question is also in your realm, Dr. Nash. Your expertise is highly valued today. What is your lab's testing capacity, and do you foresee longer data turnaround times as more and more samples are submitted for analysis?
Yes, great question. We've done everything we can to keep this as high throughput as possible, allowing us to process, as many samples as possible in a day. When we first started developing this procedure, it was so that we could process, 20 samples a day for the state of Colorado. We then expanded that to 100 and beyond, just by optimizing the procedure for throughput. So we are absolutely dedicated to keeping data turnaround times, as short as possible to make this data as impactful as possible. So right now, we can provide 100 samples within 24 hours, but we have several contingency plans in place if demand reaches higher levels, to be able to expand that in order of magnitude and still be able to provide the results within that actionable window.
Thank you, Dr. Nash. And with that, that was the final question. As is often the case, there are individuals that will have a question pop in their head an hour from now, tomorrow, next week. And so I would invite you to submit those questions via the email addresses that you see on your screen to myself at stephen.mcmanus@teledyne.com, or to Dr. Rose Nash at rose@gtmolecular.com or info@gtmolecular.com. and we would be more than happy to answer any questions that are submitted beyond today. So in closing, I would like to thank everyone for their attendance today. We appreciate you taking the time out of your busy day to spend some time with us for this very important educational presentation that Dr. Nash has joined with us today. I would especially like to express my gratitude towards Dr. Nash in taking time out of her busy day to spend with us and sharing her knowledge and expertise. It has been very appreciated. So thank you.